Okay, there we go.
Got it.
Got it. Mhm.
Let's see if we are on. Hmm.
1 minute, please. Okay, we are live. It's up to you, Andre.
Okay, I'm just checking if we are on. Oh, good morning, good afternoon, or good evening to everybody, depending on where you are. My name is Andres Sales, and I will be your host today of our event, in which we are very happy to have Dr. Juan Garay, a founding father, and someone who has a long-term commitment with the idea of health equity, and the fight for more equity in the world. And we are also very happy to receive here Dr. Manuel Urbina, who will be representing the HANA, the Health Equity Association of the Americas, and I hope I have said the name correctly. And in the event today, we will be launching a tool that was created in the process that was created by Juan and coordinated with other colleagues. That's the Global Health Equity Atlas. And without further ado, I will change my presentation for the presentation of Juan, and I'll give you the floor, Juan.
Thank you. Thank you. I, I, can you hear me well, Andre? Yes,
Yes.
everyone is fine. Well, first of all, it is a great pleasure to share with you some time this afternoon in Madrid, where I am now, and morning in the Americas, most of it, and afternoon, evening, further east. The it is really an honor to take a bit of your time, and I would really wish to have a nice debate around these concepts and this tool, which I believe within the sustainable health equity movement can be useful for many of you, and the work you do in advocating for the right to health. I think that's what unites us all. So I call it well-being in sustainable equity because just last weekend I was writing an article that I can also share with you. It's been recently published, because it is I try to start changing the concept of health, which has a lot of connotation of medicalized connotations, let's say, to well-being. And so it reads very well, WISE, well-being in sustainable equity. And you will see why I think it's wise to think of these concepts in the world today. I will also be making some mentions to what is happening now at the geopolitically and also economically at the global level, and how we should bring the concept of equity and the ethical principle of equity upfront, even I think more than ever. Next one, Andre. So what I first want to discuss with you is that we know that in an ideal world, as we have in our countries, we should have a legal framework at global level. The problem is that that legal framework is very heterogeneous. And many of the covenants and binding international treaties related to the right to health have only been signed by some countries, or there are a number of countries that have not signed up. They're not universal, and many of them really have a very low share of countries that have ratified. And there are even fewer countries that have signed up the optional protocols, which is the way to really be held accountable to that binding framework. So let's say that the overall legal framework on the right to health is very weak globally. The only and the only commitment, and it's not a legally binding commitment, the only commitment we have globally across all countries and across all regions is in the WHO Constitution, which defines health as a physical, psychological, and social state of well-being, and has a very clear WHO Constitution Article 1, which is now signed up for by almost 200 countries in the world, which aims, and we should all contribute to the best feasible level of health for all people. Next one. So, so let's put it in context. It's been 75 years ago that we have this very simplistic, let's say, but very powerful, if we are really to commit to it, common goal in global health, only common goal in global health. And you see the health progress has been really very important up until 2 years ago. This is how the World Bank estimates world average life expectancy at birth, and it has been increasing steadily in the last 75 years. Well, here is only the last 60 years. Until 2 years ago, with the COVID pandemic, where we seem to be hitting a situation that is undermining health and not only life expectancy, but expectancy of healthy life expectancy. So that is the world we're in, but it doesn't tell us much because it's just an average. We know we've lived probably the best period of humanity in terms of improving well-being as measured in the quantity of life, which is correlated with most of well-being indicators. But there's something of concern in the last 2 years. And when we look deeper into the countries, it's not just the COVID impact, there's something else going on. Next one. So it is time, I believe, to measure that common global health goal that, strangely enough, for 75 years has not been measured. It's what is the best health? It depends on whom you ask. We've used very often the highest life expectancy, for instance, to estimate the burden of disease, which has been in Japan, the best life expectancy on average for the last 30 years, men and women. But is it feasible? Probably not, in many ways that I will relate to later. So, which is best feasible level of health? So we've looked at countries that have economic means and they use economic resources below the world average. So they are replicable to all. This very simple concept is revolutionary because we've always been running after those who have the most, not only between countries, but even within our countries. We place on those who have the most in terms of economic resources and some related, let's say, privileges also in well-being as the models, but they're not replicable. There are not economic resources for all if we have those references as the way to go. But they're not the most feasible. They're not feasible models of best health in most of the high-income countries. But there's another concept which is essential in the last, we know by the turn of the century and before, that without that concept nothing works, which is the sustainability concept. So we need to think of feasibility also for the coming generations. And so it's not only working on having economic means below average, let's say a modest level of resources that can render that best feasible best level of health, but also respecting planetary boundaries. This is becoming more and more essential. You know that last week in Dubai, we had the first ever declaration on climate and health, and the first ever meeting where we start to see the very, very strong relations between what we do to the planet and what the plan and what to do at the same time to our life, to our health. So with those three concepts, we have been analyzing countries that meet those criteria. They have resources, economic resources below the average. So the level of resources could be replicable to all. They are respecting planetary boundaries. So they are models that would preserve the ecologic resources and the correlation with well-being for the coming generations. And so we've looked at those three criteria. And with those references, then not like in the burden of disease with the best reference that is not replicable nor sustainable. There's, by the way, a high correlation between not being economically replicable and not being ecologically sustainable. And with those references, now we can, as it was done from the 90s on the burden of disease, we can assess the burden of health inequity, which measures the deficit from the global health goal, the only common global health goal. And we can measure it in excess mortality or in life years lost from those best feasible levels of health, or we can measure it in the proportion of deaths which are in excess of those references. So we call it burden of health inequity, and we believe it's a very strong measure of social justice and sustainable social justice, and as I said, well-being in sustainable health equity. Next one. So this is when we use that methodology, sorry, I also have my bell here. When we use that methodology, we can see that the burden of health inequity in just by international comparison between average life expectancies by age and sex groups and by quinquennium, that's every 5 years when we have the UN Population Division releasing its data on estimates population and deaths, we can see that the burden of health inequity has been evolving. It decreased in the 60s and more moderately in the 70s, but it has remained basically stagnant since the 1980s. And you see 3 lines there because we've been using every 5 years more, let's say, refined indicators. First, it was just life expectancy, GDP per capita, and carbon emissions. And now we have, for each of those 3 criteria, we compare the GDP, the GNI, the constant value, the PPP, the economic side, much discussed with economists. On ecology, we are also taking data and working with the ecological footprint network. So it's not just carbon emissions, but ecological footprint and biocapacity per capita and so on. And life expectancy also is disaggregated by men and women, and also taking into account healthy life expectancy. But with all of those, with just a point variation, which I could explain, those methodologies are quite constant, quite consistent, and they talk of a burden of health inequity in the region of 16 to 17 million excess deaths in the world that could be associated with basically global injustice, global international injustice. And I would say later how the international comparison has a limitation because, of course, national averages hide a lot of subnational inequity. So we will see later how the smaller the sample and the higher the sample size, the more sensitivity and probably this figure would increase significantly. We can also see in the graph of the upper right how that burden of health inequity can be measured, as I said, and more comparable on the relative burden of health inequity. We call it the proportion of all deaths in the world or in a given country or in a given group or in a given age group or sex group, given time, which are in excess of what would be expected in those reference models. So a 30% relative burden of health inequity means that 30% of the deaths in that given population are in excess of those feasible levels of health the world could perfectly achieve with the resources it has while preserving ecological resources for coming generations. So you see the evolution as well there of both all the population in blue, women in pink and men in gray. And you see that there has been some decrease in the last 20 years. So the denominator has increased, the total population, and the relative burden has decreased from 40 to around 33, 35%. More in women have a significantly higher relative burden of health inequity than men. And that decrease, to be fair, when we've analyzed it in detail, has a lot to do with the decrease of the burden of disease in the last 20 years in China. And if you extract China from the equation, there's only a very moderate decrease on the relative burden of health inequity. When we in the graphs below, just very quickly, you see the last 5-year average. On the lower left, you see the age distribution for women, and on the lower right, the age distribution for men, also in terms of relative burden of health inequity, proportion index in excess of the best level of feasible level of health. And you see that in women, while there is a similar relative burden than in men in the first 15 years of age, it remains higher in the reproductive age group. So there's an excess burden of health inequity in women in that age group, but not just from 15 to 45 years of age, but in the post-reproductive age group. So from 45 to 65, it also remains quite higher than in men. So these are, for instance, that very group of, let's say, post-reproductive age group in women is not normally picked up by the usual statistics. And this analysis of the burden of health inequity identifies at global level that significant challenge. I'm very happy that Rocio is in our call, and she has a lot of work in access, for instance, to diagnosis and treatment of women's cancer, which I feel is one of the causes which is increasing, and of ill health and the burden of ill health and inequity, and among other reasons. But of course, this is a world average. The atlas, as I will show you later, allows you to look at each of these graphs by country, by age group, by time, and of course assess it in the local context. Next one, Andre. So if you click here, Andre, on the there's a play button. I'm disabled. It's lower down. Yeah, I think you should be clicking there. Oh no, next one, previous.
No, wait. If you need me to play a video on it, I need to come here. I think you're talking about this, and luckily it will work.
It's good to have No, you see, I see the play button here, just on the left. Yeah, it should work.
Yeah, actually, no, because you just captured the screen. This is not a video. This is just an image.
Well, oh, so sorry. In my screen, it was working. But anyway, let's leave it there. What this video would have shown to you, and so sorry it doesn't work, is that the evolution, probably some of you have seen this graph before, and we can see it probably later in the atlas. The evolution of life expectancy in different countries, and here the bubbles are correlated with the population size, has evolved over time. And there's, of course, a correlation of greater GDP, greater resources, greater economic access to many of the factors influencing well-being, and greater life expectancy. But what is interesting, and here I come introducing a fascinating concept, is that after a certain level of resources, you reach a flat line, and health expectancy and many other well-being indicators do not increase any longer. And this is beginning, so I call that, and you will see later in the analysis, I call that threshold, whereby after that level, well-being in terms of life expectancy, healthy life expectancy, and other indicators does not improve. I used to call it the hoarding level, above which you continue to accumulate income, and in fact, a lot of the income, GDP, wealth in the world is accumulated above that threshold. And it doesn't serve well-being. It doesn't serve humanity in terms of well-being. And of course, it undermines equity. And what is interesting is that above that threshold, no country has respected planetary boundaries. So this is beginning to be called waste GDP. And I will show you later. I will elaborate on that in a moment. Pity this video didn't work, but there you are. So I will leave you with the appetite. Next one. So what the analysis of those models also tells us in terms of the economy is that there is a certain level of income per capita in terms of GDP, and we know GDP is a very, very imperfect measure. It correlates with income, but there's a great variation across countries, particularly in high-income countries. But there is something called we call the dignity threshold, which is the level of income below which, and this changes. This is a shifting equity curve across time. Below that level of dignity threshold, no country has never been able to enjoy that best feasible level of health. So if you're born in a situation where your income is below that level, you're basically deprived from the right of health. There may be exceptions, but on average, your life expectancy will be lower than those feasible levels for all. That's the dignity threshold. There is an average on the use of resources, which should be in balance with planetary boundaries, the way we use economic resources, preserving ecological resources. So the dignity threshold is already quite, I say, a quite transforming concept, because it's now in the region of $10 per person a year, and that needs to be adjusted to purchasing power parity across countries, and of course it evolves with time, and it is 5 times higher than the poverty threshold set by the World Bank. So there's a large group of the population, probably around 40% of the world's population, which is between poverty and dignity. And you may say they have escaped poverty, but they are disentitled, they're deprived of the right to health. So this is a first, I think, very important concept to keep in mind, the challenge of poverty concepts and the logic of addressing dignity as a threshold above which human rights, starting from the right to health, are not ensured but are feasible. And there is another very important concept, which is on the extreme right, which is the excess threshold. And as I mentioned before, there is a point above which well-being does not increase any longer, and we see it when we look at subnational examples. There are fascinating examples that with $50 per person a year, these are called blue spots, and they're called sub-regional equity analysis. We have lots of evidence that there are some very good examples of well-being in the highest levels of life expectancy and healthy life expectancy, above which the concentration of income, generation of income, concentration in a few hands, because you will see later how the world looks like in terms of the distribution versus this equity curve, does not improve, and they have also a negative effect on coming generations through excess carbon emissions and excess ecological footprint. So this is in a way what Plato said 2,300 years ago, that societies should ensure a good level of life standards for everyone, but also prevent from excess accumulation. He said it 2,300 years ago. So this is a concept which is very difficult, because as I said before, our societies, most of them in the free market economies and socio-political understanding of dynamics, they associate the highest GDP and the highest levels of wealth as the standards of progress. For instance, the Human Development Index, if you look at it in the last 25 years, every year, the ranking of the countries with highest human development are those in the higher income range. So that is the excess threshold, so to say, is also a very, very important concept to challenge the way the world has been functioning since the 80s, when the burden of health inequity, the level of injustice has remained almost untouched. And then there's a fourth concept. So you have dignity, access, planetary boundaries. Plato did not talk about that. So, but we know now that it is really important. And the mobility within that limited range, which you see is far more limited than the present range of inequalities, on how a society rewards those who contribute most to common good. Next one. So this is, the previous one is how the world should look like, but this is how the world is in a way. You see here the equity curve between the dignity and the excess threshold. It is in yellow in terms of the distribution of the population. What ideally an equity curve would be in distribution of the population, slightly biased to the right, because of course within that curve those who are on the right side have more resources, so you have that slightly biased distribution of resources. But what the world looks like is, in terms of population, you see the dotted yellow line on the left, and you see there that there's a huge peak of population. I mean, this is, of course, a smooth curve in relation to what we have been plotting in terms of countries, in terms of their GDP and cumulative population, but a large proportion of the population remains below the dignity threshold. At the present time is around 50%. Then there is a population that is within the equity curve, and there's also a peak of population, particularly much higher above the excess threshold. You see it on the right little bump here on of the yellow dotted line. Yeah. So we have a good coordination, Andrea and I, with showing the slides. And the blue dotted line sees the distribution of resources. And you see there's a large distribution of resources on the right side, where GDP per capita is higher, and there's this bump of excess accumulation. And it is then it goes down in the equity curve, and there's a bump correlated with a large population on the left side, under the what we call the deficit zone. Next one. So I wonder if this will neither work. Can you click and see if it works? Because this is another, no, well, don't worry. This is in fact the why we started doing the atlas, because then we saw, okay, we have the concept of economic equity between dignity and excess, and I will explain a few of the consequences in a moment. We have the distribution of the population globally and sorry, by national and international distribution, and we have the distribution of resources. So you can have a moving video. This is what this would show, but it is in the atlas, whereby the equity curve moves with time, because of course the translation of ecologic into economic resources shifts in time, and that equity curve is moving. Another important difference to the poverty thresholds that have been stagnant for decades, and then they adjust them and they remain for a long time. Every year, the dignity and the excess threshold keeps changing. And you have also how the world population and the world resources are distributed. And you can see in a map there how here represented in basically in red, but this was in the 1960s, I think, what the world looked like in terms of countries in the deficit zone, countries in the equity zone, countries in the excess zone. And you can see in the graph on the right side of the map, the proportion of the population that lives in countries in the deficit zone, therefore with GDP per capita below that dignity threshold, the proportion that lives in the equity zone, and the proportion that lives in the excess zone. And you can see this is just a snapshot, so you don't, because this is from the 60s, it has been evolving a lot. I think I have some graphs later on. And on the right side of that bar, you see the distribution of resources, and you see that over 80% of resources remain in those countries in the hoarding or in the excess accumulation, while the rest of resources remains partly in the equity, and half of the population has less than 10% of the resources because they live in the deficit zone. And the graph also, and this moving graph and map also says here on the right side in Spanish that it can estimate the excess mortality by inequity and the proportion of all deaths which are in excess of those best feasible levels. Next one, Andre. So besides that burden of health inequity, this tragic loss of life year after life because of an unfair economic world order, we have the ecological dimension. And the ecological dimension is really worrying as well. As I said, we've witnessed last week the Health and Climate World Declaration at Dubai. There's now recognition, but it's coming very late, of the huge impact of the ecological destruction of humankind in our own health, and of course the health of many other species. Through some studies I was involved, we can estimate that just by the current trend of emissions, which has not changed much after all the commitments of the COP Conference of Parties on Climate Change, we can estimate that at the current trend, the temperature increase would cause some excess of 220 million deaths in the rest of the century. And the double-edged inequity here is that this huge excess of mortality, which will be it will be affecting mainly countries that have polluted less, that have had less cumulative carbon emissions, and the generations that were born after the 1990, which are probably the most conscious about climate change, and they may be trying hard, but in systems which are not very amenable to alternative ways of life to reduce their emissions. So this is the double-edged inequity of our impact on trespassing the ecologic planetary boundaries. And you see, just as many of us here are health professionals, that we could correlate this global warming with fever. It's a very interesting coincidence that we see that fever is when we have 1.5 degree above our base temperature, and we reach 37.5 or above. And this is the same symptom that the planet has of fever. We know when we trespass the 1.5 degree above the pre-industrial levels, the planet will be probably in a point of no return and devastating damage of its own ecological cycles. And it's correlated with another factor, which is probably we know less on how it's going to affect it, but it's the loss of biodiversity, which in fact already is creating a lot of damage in other species, and loss of life in other species that in our anthropocentric, let's say, culture, we're not so sensitive to. We have the deforestation. We are also distorting the cycles of nitrogen, phosphorus, and hydrogen, which is similar in a way to what diabetes or many of our chronic diseases mean to our body. We're losing groundwater. The planet is being dehydrated and is being heavily intoxicated by over 70,000 chemical toxic substances that humans we use for our, let's say, progress and well-being. So this is really essential to think about. On the upper right, you will see the logo of an app you can also download in your mobile phone to estimate your carbon footprint and correlate with the ethical threshold above which your carbon emissions will be contributing in a net way to this disaster, and where there is a very, very clear correlation of excess income above the excess threshold I was mentioning before, and the burden of health inequity, and the impact on the burden of health inequity, and the excess carbon emissions. So the more you accumulate, either by consumption or either by savings and financial speculation of your savings, the more you contribute to global warming and all the other effects of ecological destruction. Next one. So what I'm coming to the end to give you a rapid tour through the atlas. So what needs to be done to progress towards that common global health goal that has never been really measured in terms of identifying the best feasible levels of health and then assessing the level of burden of health. First of all, we need to reduce international and subnational economic inequity. So there are many countries that have not been able to enjoy that best feasible level of health with a GDP of at the current constant value of $10, which is 5 times the World Bank poverty line. The redistribution required for that, almost half of the population living under the dignity threshold, would mean that 7% of the world's GDP would need to be redistributed to lower income countries. We see that as utopia, but for instance, in Europe, we redistribute our resources, what the market produces in terms of production and consumption, from 30 to 40% of the GDP. We do it through fiscal equity, through public spending, and we keep, let's say, our approach to universal services and universal rights with a redistribution level of 30 to 40% of our GDP. And we see it out of any feasible, let's say, reality that we think of a 7% world's distribution of GDP. And not only there's that contradiction that internally we see it logical and for others we see it out of question, but also that 7% of the world's GDP, around $6 trillion, is very similar to the level of tax evasions, the level of resources that are in tax havens. And may I say, for instance, that recently the UN failed approved a resolution to start developing through terms of reference and a negotiating process the UN tax treaty, which is basically trying to see how financial resources are concentrated in tax havens, sort of black holes of wealth, and of course basically bleeding many countries from those resources through tax evasions and money laundering and many let's say perverse economic dynamics. And what is interesting and I would say really shameful for the high income countries we live in, and I live in, and I also work for, none of the high income countries voted in favor of developing a UN tax treaty, with reasoning that I fail to understand. But in any case, that will start. It was proposed by the Africa Group, and there will be a terms of reference, a negotiating process, and a goal of setting a UN tax treaty, and the high-income countries remain invited to join that minimum level of justice. For instance, oil subsidies that have been discussed recently in Dubai, also they have a very high level of the GDP. It's not 7%, but it may be half of that level. And if instead of promoting destruction, human and planetary destruction, we promote social justice, we could have significant and sufficient resources to start to roll back this massive burden of health inequity, or military spending on others. So the world is hugely unfair. It needs a minimum level of redistribution. And of course, as you know, official development aid does not reach 0.2% of the world's GDP. And the commitments of reaching 0.7% of OECD countries has remained elusive for now 50 years. So this is the level of, how can I say, sensitivity, solidarity, and justice that the world lives in. It's a very unfair international economic order. So besides reducing economic inequity, we need a new economic order promoting social justice, respect to rights, healthy lifestyles with more physical activity, local and healthy diets, reduced tobacco and alcohol, and reduced stress. This is this is this is taking place, but in such a slow pace that it's that first of all, we do not have the necessary impact in through changing our lifestyles, particularly in high-income countries, high-polluting countries, to reduce carbon emissions and to also better our own health. And it's very much related to the burden of non-communicable diseases, the competitive and high consumption life. Third, we need to ensure sufficient health spending. When we come to the health systems, we know that there are, so we can also correlate those and remember those models I mentioned on best feasible levels of health also have an average of health spending per capita. And if we relate to that minimum level of health spending per capita, below which no country, although the main influencing factor is the income, the overall income and GDP, has been able to enjoy the best feasible level of health, then the gap is in the region of 300, 400, and by some estimates even more billions per year of recurring costs that those low-income countries cannot meet. And this is, for recurring costs, we mean the salaries of nurses and doctors, the essential medicines, the basic logistics to allow the basic level of quality care. That 400 billion also compares to 20 times less in terms of global health aid spending, so, which is hugely insufficient. And there's also a lot of bias. I couldn't elaborate on that because in my capacity now, I'm talking here as an academic, but I also lead and coordinate the health team in the EU cooperation policies and programs, and that health development aid architecture is not only really low, it's like 5% of what's needed, but it's not really targeting and concentrating neither in low-income countries, neither in recurrent costs. It's more and more on vertical programs, on investments that fall on a desert, let's say, on a very dry land of limited resources to have basic healthcare delivery. Next one, Andre. And the last two things that I think should be really important is revert the dynamics of trespassing planetary boundaries due to excess scale production, global trade and consumption, and oil-based economies by promoting universal understanding of sustainable life cycles. So the previous three bullets of let's say conclusions have a lot to do with an economic order which is often beyond the capacities of citizens and communities to influence. It really requires political action. But there are things we can do as citizens, like having sustainable lifestyles, and at least at our level try to reduce our carbon emissions and prevent this global economy in our little contribution to keep ruling the world. And then, of course, there is with climate change. There, I just mentioned the burden of ill health and the excess mortality due to global warming, but there are many other effects, as I was saying: loss of biodiversity, loss of groundwater, deforestation, etc., and many factors which are influencing pandemics, very likely future pandemics. So we need to work better around being prepared to detect, react, and also ensure equity in the very likely next pandemic, and try to prevent what has happened with COVID in terms of COVID nationalism and COVID hoarding, because in a way, what has happened to COVID reflects very much what happened to the world economy. Resources, be it money, be it food, be it vaccines are hoarded by just we could see very similar skewed distributions, right? So this being dealt in the pandemic treaty with a major confrontation north and south that needs to probably be bridged by greater sensitivity and solidarity. Let's hope that in the next months that may happen. Next one, and I'm coming to the end before I give you a quick tour. So these are just the slides, but I'll show you in a moment where it's hosted. Oh, sorry, it's in, because this was under the previous presentation I sent to you. I translated to English, but don't worry. I've been analyzing for the last 15 years on every 5 years some 2 million data that comes from different international organizations, World Bank, WHO, and the ecological footprint, the UN population division, some economic database analyzed by other networks. And with that analysis, we've been able to assess this shifting curve, first shifting levels of feasible levels of health by age and sex group and country and time period, and how that has allowed us to identify healthy, replicable, and sustainable models, what we call now WISE, well-being in sustainable health equity models, and therefore estimate the burden of health inequity by country, by age group, by sex group, by time, but also the other related indicators that you will see in a moment. The graph on the right shows the dashboard, the interacting dashboard you can access. And this is, as I said, done from 1960 till now, every 5 years, and from every 5-year age group, from 5 to 100, and of course by sex disaggregation. And you can use it by looking at economic indicators, ecologic indicators, life expectancy and healthy life expectancy indicators, and then the burden of health inequity in net and relative terms. And also something I will almost end here, which is what I call the WISE index, which is the life expectancy to which we deduct the negative impact on others through excess accumulation and through excess carbon emissions. We can estimate how much of the excess accumulation hinders the population in the deficit zone to access the equity zone and be enabled, of course, with other factors to enjoy that best feasible level of health. So you can correlate excess GDP with an impact on life years lost by those who do not have enough, if that minimum level of redistribution is not in place. And we can also estimate from that excess number of deaths due to global warming, what would be the correlation between excess carbon emissions. Even individually, you can tell by your excess carbon emissions, if you dare to estimate what is being your negative impact on the coming generation in life years lost. So if you deduct your average life expectancy at birth from those two negative impact on others, then you have the WISE index, which is very, very, very different to the Human Development Index. Next one. And the Atlas also has a profile on every country of the 117 countries assessed with more than 100,000 inhabitants. And you will see that, let's say, equity profile in each country has some 20 graphs of all those ecologic, economic, well-being, and burden of inequity, and the WISE index indicators, and how it has been evolving in time. And there's also a link in the Atlas with mapping of those indicators and seeing how they evolve in time. So it's a time dynamic maps, and there are also some 40 video tutorials explaining each of those indicators, how they evolve in time. Next one. And this is, I'm just...
Juan, can you hear me?
Yes, I can hear you.
We are around 15 minutes. We invite people for a 80-minute seminar. So if you could start wrapping up.
In fact, these are the 2 extra slides, which were not so needed, but I think it was interesting just to end up saying that international analysis is interesting, but it's insufficient. And we need to have data at subnational level to understand good subnational references of feasible level of health, and a subnational analysis and mapping of burden of health inequity. So this is for Europe. Next one, I could explain. Next one, this is for different countries, major countries on sub-regional analysis. Next one. And I think that's the end. Thank you. So do you want to do the quick tour yourself, Andres? So your voice will at least mean a change to the audience, or shall I? Or shall we not? Or shall we not?
If I will, well, first, let me stop sharing the screen so you can see me. Thank you very much, Juan. I feel like we are all learning how to move forward with the Atlas, which is a very important tool, and a tool that we're going to release the webinar series to explore more. And as someone who also get excited about the possibilities, I see you want to go through all these concepts and show as much as we can. My suggestion for right now would be lead the floor to Dr. Manuel Urbina, and then oh God,
Please.
it's asking me. I'm talking. Confirm what language I'm speaking. Sorry. And then I would show the page in which we have the Atlas on Sham, and then give a quick tour for that. How does it sound?
That sounds good. And may I also say, Andre, that you may announce that we will be having a series of 5 webinars. So because this is too high concentration of information, and in each of these webinars we will be reviewing different dimensions of these concepts of equity and metrics and use of the Atlas. So we don't need to do it fully now.
Exactly.
So please.
When I say that I would like to present the page, is that the page we announced exactly this, because we are seeing the Atlas as a very strong tool that we need to learn how to use and to relate to. And this event is a way of us just starting this conversation, but with no intention of ending it right now, because it's too much information, as Dr. Manuel Urbina joined in. As someone hearing you, I understand now way better the things I wrote and put on the website based on your work. So thank you for that. Shall we leave the floor for Dr. Urbina?
Okay, please do.
Thank you very much.
Can you put the presentation, please, Rene? Okay. Already is in the screen, the presentation?
It's not yet. Your presentation is not yet.
Okay.
It's coming. It is now.
Okay. Is the full screen? Because I cannot see it in my computer. It's okay?
It is. It is okay. It's full screen is perfect.
Okay. Well, first of all, I would like to thank Andre and Juan Garay the opportunity to participate in this presentation of the Global Health Equity. Already he changed the name, but doesn't matter. It's WISE. I like more the WISE probably. And on behalf of the Health Equity Network of the Americas, and thanks to Rocio Sainz and the group for allowing me to represent them. The information in the Atlas, as we hear, Juan, is extensive and detailed, require many hours and days to analyze. Due to the analysis scheme used in the Atlas for each country, they are a wealthy source of data, and the original format allows to see health disparities taking into account geographical, socioeconomic, and ecological factors. The health equity data analysis and mapping significantly represents by its flags, which is very nice. It's an addition to the graph and explanatory videos motivate me to see the results for Canada, the United States, and Mexico. By the way, there is no equity in the information since the data of the United States is more than those presented for Canada and Mexico. The 23 and 3 tables, they are more than that. So it's not equity, Juan. I believe that the challenge with this Atlas information is to motivate to be used for decision making and the design of interventions that truly reduce inequities. The dimension of global challenges for sustainable development and its link with health in environment and global risk with local impact. That's why it's very important, this proposition of sub-national analysis. I want to share with you some pictures to illustrate how complex it is to achieve this multi-sectorial participation with a little funding for health. For example, it's the same for education and other programs. Well, first of all, the inequality crisis that we have in Latin America. Nothing new, but will remain number one. So the rich 10 of the population captures 22 times more of the national income than the bottom 10. The richest 1% takes 21% of the income of the entire economy, double average in the industrialized world. Sex, race, ethnicity, like income are powerful determinants of access to healthcare, education, employment, and the legal system, as Juan is clearly explained also. Inequalities start early in life and widen during the childhood and adolescence, with the result of children from different backgrounds that have unequal opportunities to grow and develop. So we are now we all share the credit to closing gaps, but there are also new inequalities that result from the social determinants of health. So we can see a boy with his adolescent mother, or a child and a mother with a plane and a tablet. So that's why I consider very important that the Commission of Social Determinants of Health establish all the dimensions for these effects of social, economic, and political crisis. And these three important recommendations: improving living conditions, fight against unequal distribution of power, money, and resources. It's the first time they utilize power and money in WHO. Measure analysis and the problem. I want to stress that the proposal is that we need a generation to change, and that means 25 years, according with the country. So the importance of public policies globally and such country address the social determinants of health is the magnitude or scenarios that we need to see it. So we have a lot of information, and an example is the health in all policies we have been talking about since 1914. And the impact is this: for those who decide between various policies and the design of implementation strategies. When the expected impacts are of current policies and financing are quantified, we don't quantify, we don't analyze the impacts. So the objective is to improve policy formulation based on results, and for decision makers to be clear about the link between policies and interventions in social determinants, primary healthcare, universal coverage, and climate change. Research for the results reduce or abate the major causes of mortality and morbidity, which are not modified with the existing health models that we utilize. So when we talk about public policies, now we are conditioned by 5 mega trends: the demographic and epidemiological transition, Juan already mentioned, voluntary and forces of involuntary migration, accelerated and disorderly urban growth, economic recession, increase in poverty and inequalities, climate change, and globalization, both economic and technological. But when we formulate policies and programs, the following should be considered: the proximate causes of the people and problems, the causes of the causes, the social determinants of inequality, and the causes of the causes of the causes. That means public policies. And that's why the Lancet and University also have a commission for governments for health. And they stress the political origins of health inequity, and they propose prospects for change. So the political policies are very important, and we need to consider with this amount of information that now is available with the Atlas. So social position shapes not only the results of an exposure of vulnerability of people experience, but put their life at risk, since it places them in an unequal position of power, prestige, and excess of resources and services. So we know that the social determinants of health are the conditions in which we are born, grow, live, educate, work, age, and die. We don't choose our parents or where to born. So that's the condition. We are very lucky to be talking here, and we are privileged. So we have a framework. Everybody knows both of this framework, the structural determinants and the intermediate determinants. And in the healthcare system, we cannot move or change too much about the socioeconomic and political context. So governance, policy, and macroeconomic are the conditions of this social stratification that we have around the world, in rich and in poor countries. But when we analyze the population approach and the individual approach, we are seeing that we are only talking about the effects or interventions about the effects. And those are the curative care and are the 3 levels of attention. We advance with primary health care and health promotion as intermediate variables, as well as the risk factors, with information, education, and communication, and community participation, and primary healthcare. But inequalities needs a multi-sectoral participation, the three levels of governments, federal, state, and local, institutional, interdisciplinary, public, social, and private. And we have four areas that I will mention later. So the structural determinants are the causes. And if we don't put together economic, political, and social sector, as well as the public and private sector for health management, we're never going to have this future-wise that we are looking for. Already, we know that we are more than 8 billion human beings, and the growth will be in our countries, not in developed countries. Just since the 2000 to the 2030, we are going to have 2 billion more human beings. So the on-planet urban growth and housing is one of the problems of sanitary conditions and critical determinants. This is a picture, aerial picture of houses in one state in Mexico. It's called Ciudad Nezahualcóyotl. Juan, you probably know that place. And they live more than 1 million in this small space. When we compare this with the tulip leaves fields of bloom in Lis in Netherlands, you see the difference between one and the other. So we are now in an uncertain world with food, water, and energy. So we need to manage those resources. And that's one of the problems I already mentioned, that we are safe in just in a space of humanity with this DONA, they call about the environment resilience, the social foundation, and the inclusive sustainable economics development. But already 7 of the 9 limits have been exceeded, as was mentioned this in the past COP28, suggesting that there is now well outside of the safe operating space for humanity. Ocean acidification, the stratospheric ozone levels have reduced slightly, and the level has increased in all the limits previously identified and has exceeded. The Davos meeting at the beginning of this year established for the report of this year that the Global Risk Perception Survey, climate change, energy supply crisis, cost of living crisis, rising inflation, food supply crisis, and cyber attacks on critical infrastructure. They discovered in 2011 that the problem of climate change appeared. So there are these analyses, most of them are not well known, but only I want to stress that there still is a big concern for the economies. We know that more than 849 million hectares of natural land, almost like the size of Brazil, are at risk of degradation. Feeding increased number of people is another problem. And for this World Economic Forum, the Global Risk Report, they say this is the year of polycrisis, because they said we have run out of words to describe what's happening in the world today. So this edition has used a new one, polycrisis. It's a situation where different risks pulling and their independency is actually felt. So we are going to suffer agricultural problems with the loss for the degradation of the soil. The lives are going to be lost by the year 2030 because of climate change, and the severe water stress by the 2050. We have the pollution around the world, the wildfire also, and the rivers are like this, the Seven Creek Gold King in the gold mine, contamination with 11.4 million liters of water with toxic waste and high levels of arsenic. So we know the impact and health of climate change. Air pollution changes, as already Juan mentioned, I don't want to repeat that. Temperature is growing, increased levels of CO2, increased levels of Pro-C, but the change in vector ecology is very important because we are now suffering from dengue. And this is one of the graphics I really want to emphasize. We are those that born in 1950, and myself 2 years earlier. And we are now suffering the consequences of this climate change with the increase of temperature. And for those who born in 1980, when they reach the 70 years of age in the 2050, they are going to be very much affected But those who born in 2020, when they reach the age of 20 in the year 2090, they really are going to suffer the consequences if we don't do anything. And now we are suffering already the consequence at the beginning. So this is a very high risk that I see this very impact graphic that show us the consequences. So drastic inequalities dominate the world and involve all rich and poor countries. Why have no achieved equitable social and social justice policies operation with efficient quality of services to achieve health equity through universal health coverage, for example? Because we don't invest in health as well in another social programs such as education, housing, and employment. Because what we have in Spain is for infrastructure or payroll with high administration costs, food management, and corruption. Because we don't evaluate the performance on impact and what the sectors responsible of social policies do. Here's the graphic GDP that part of the analysis of the Atlas mentioned. Mexico is in the last place. This is a very interesting health spending in Mexico. We are in the last place, but Mexico is a country with very low health spending per capita, but is a country with one of the highest pharmaceutical spending, according to the CEO. So why? Because people don't have access to services and they have to spend. So the question is, why treat the people and return them to the living conditions that make them sick? Why serve the population without changes in the sanitary conditions in which they live? The lack of transportation and adequate roads limit the condition of access. Almost 4 out of 10 people, more than 51 million in the case of Mexico, suffer from the lack of access to health services. This means that 30 million were left without access, the vast majority of the most vulnerable households. Additionally, the number of households experiences catastrophic healthcare expenses double reach almost 5 million. Education. We still have the problem, 1 in 5 children or young people, more than 25 million in total, experience deprivation due to the education lack. Since they don't have compulsory education and don't attend the formal education center. Some live and sleep in the street, others need to work at early age. So tertiary early childhood education in US dollars, Mexico is in very bad shape. And we can see that according with the education spending, that we are not investing enough for education. So we must select the high operational options and priorities to achieve international, national, and public and private intersectoral participation. And I'm very glad that now we have this tool available to utilize information and make decisions with basic and data. So, but at the same time, since 2015, with this 17 social sustainable development goals, we have now options to measure the impact of multi-sectoral intervention and contribute with economic, social, and environmental dimensions. And now we address the consideration of these social determinants of health with the 10 principles of the United Nations Global Compact. And this year, a collective vision of the place for zero health gaps. So we know the 169 goals, the 231 indicators, and that the vision is to keep the increase of the planet's temperature below 1.5 degrees Celsius. And the dimensions that each of these has to be in economic, social, and environmental approach. These 10 principles that utilize the analysis of human rights, labor, environment, and anti-corruption are well identified now in each of the 17 social sustainable development goals. And the Global Health Equity Network, Zero Health Gap Pledge, now, because the result of Health Equity Network from the World Economic Forum, they proposed that the gap in life expectancy between Japan and Lesotho, for example, is 30 years. And the reduction of life expectancy is tremendous, even in Mexico, the United States, United Kingdom. So something is happening besides the pandemic, the COVID-19. So a company that operates with health equity as a core principle is more likely to increase customer trust and loyalty. The communities where people live, play, and interact directly influence their health. Yet another reason for organizations to work with communities to promote health. More than 100 companies already signed this Zero Health Gap pledge. So the structural and intermediate social determinants of health correspond to the 17 social sustainable goals. They already have goals and indicators to evaluate. And if we added up this data from the atlas, we can really operate where we should act and support and intervene. The place we live, the place we study, the place we work, and the place we have entertainment. Already they're very well identified. So we also have the essential public health functions, and they added up social determinants of health recently. We have the syndemic vision after the SARS-CoV-2, not just for obesity. So we have the micro, the meso, and the macro systems and governance for analyzing natural system, norms, economics, transport, urban design, workplaces, families, communities, and social circles. We have One Health to analyze those zoonotic infections as well as the comparative medicine and the translational medicine. So we have tools. And now we need to think for the future. It's a group that proposed the 6 key transformation to achieve the Sustainable Development Goals based on major drivers of society change: human capacity and demography, consumption and production, decarbonization and energy, food, biosphere and water, smart cities, and digital revolution. We are in the fourth industrial revolution, and now we are moving in this way. So this is my reaction to your very vast and interesting document that you published, Juan, and congratulations for this new tool. And I hope really that can be utilized and see the complicated way that we need to run and to work in order to really utilize this data, and that the social policies and politicians and parliamentarians make enough effort to do the best in order to change these inequalities that we are suffering. Thank you very much.
Stop. Thank you very much, Dr. Manuel. It's a very comprehensive presentation. I'm a little bit concerned in terms of time because we were initially thought in opening the floor for comments and reactions. I will stop video. Yes, I will stop your video. Have I? Yes, and try to share mine. Just to give you a brief overview of how we can see this tool that Dr. Juan has developed inside of the movement that we've been creating around sustainable health equity. I'm inviting you to take a look on the Shane webpage because you work through working groups, and now we have a lot of information on the conceptual proposed by Dr. Juan in this thematic working group that we call Equity Concepts and Metrics. That's the page I'm showing to you, in which we kind of summarize and present the concept. We have a web link to the atlas, and I will click here in a second. We have here some important materials that we select in the library, in which you can read more about the proposal and how we can move from an evaluation of different indicators and index that not give us the real way to grasp the impact of inequalities. And if I understood correctly, what one is proposing with the atlas and then with the concept that he's bringing to the forefront is that to be more mindful of how much are we living due to inequalities. So the tool is very important because it helps us to have data and substantiate it. And at the same time, it provides us a framework in which we can understand what are the main fronts of action that are totally in line with those presented by right now in the presentation that we just heard with the key points of action. I think we are absolutely aligned. And as we mentioned, this is an event that aims to open a series of webinars that we're going to be hosting here, Dr. Juan and I, and the members of the SHAM thematic working group on equity concepts and metrics that will be promoted here. You're going to be receiving this material over email, and we'll be promoting this webinar here, and you're going to be able to see the topics and join us. And we truly hope that by creating this webinar series, we can create more awareness about this tool and about how people can use it. And if you're still with us, I'm clicking on the Atlas per se, so we can see it's a little bit of its options. You have the indicators here, the videos that Juan has mentioned. And if we click, then you can combine them and you can create your own perspectives for analysis. And it's a very comprehensive atlas, and we're going to be a very comprehensive tool, and we're going to be diving into it in the webinar series and covering the implication of the specific dimensions of the atlas. Just to not, I'm just, sorry, something appeared here. Oh, no, you're seeing my whole screen. Yeah. So, where are you? I would like to stop sharing my screen now. And sorry, I wasn't seeing anything. And if we still have a little bit of time, we are over 5 minutes, but if we could stay for 10 minutes to hear a little bit from our audience, it would be good. And I can guarantee you that in the next few days, you're going to be receiving the video from this webinar, and please share with your network. You're going to receive a link straight to the Atlas, so you can access and play with it. You're going to receive a link for that thematic working group web page, the presentations made by our speakers, so that you and everybody who have registered for this activity can feel compelled to come back to be talking with us about this in January, when we are January or February, when we'll be launching the webinar series. Thank you very much. And I would like to open the floor if anyone has any comment. Caroline, you have the floor.
Hello, can you hear me? Okay.
Yes.
Well, thank you so much for sharing, your group with me. My name is Caroline. I work for WHO. I met Juan recently and we talked a bit, so he invited me to join this very interesting network. And I just had a few questions to Juan and to Dr. Manuel, if it's okay, because I know that WHO is in the preparation of the new, we call it the Michael Marmot report. And I saw, Dr. Manuel, you made a reference to WHO's framework, from 2008. But I was wondering if you have reached out to WHO, because the World Report on Social Determinants of Health and Equity will be presented to the World Health Assembly in 2024. And at the moment, they have developed a new operational framework to measure social determinants and health equity. And I don't know if you have, if your atlas, the concept, the indicators that you have is in the new, it's still a draft operational framework, but it's going to the executive board in January. And I know that the World Report is also in finalization, but I would say this has to be in the World Report. But I'm very happy to consolidate and to share, to link my colleagues, because I work in Brussels in a very small office, but I can, of course, make the suitable connections if you believe that that is possible or needed. That's my first point. And the second point I wanted to also quickly reflect. Coincidentally, Juan, you were talking on the right to health, and I'm an editorial advisor to the WHO Bulletin. And this week we had a paper submitted to the Bulletin that speaks on an author that is, I think, from Harvard, that was proposing a new way of measuring right to health. And in fact, this paper was requested by the WHO Council of Economics and Health for All, which is a bit more a political council, because it was set up by the Director General with a big group and this and that. And they looked into 6 case studies of countries And this author has his own framework of measurements of right for, on equity, right for health, looking also at the legal framework and this and that. So also my question to Juan would be, have you already linked with the WHO Council on Economics of Health for All? Because I think the time is really right. There are two different things, of course. The World Report is, very institutional, member state driven, and this and that. While the Council is a movement and also supported by a group of countries. I think Switzerland, the University of Lausanne, and I don't know who else is in there. But these are two things that I was thinking could be very interesting, and I wanted to know how you think that could connect over.
Thank you. If I may, Andre and Manuel, shall I start? Well,
Yeah,
first of all, thanks so much for being here, Caroline. We are now living and working closely in Brussels, and there are opportunities to try to move some things politically. On the two reports you mentioned, no, I myself have not addressed them. Of course, Michael is part of our board in the Sustainable Health Equity Movement, and we have been sharing this information in the past, and he's very committed to it as well. So we will, I think, Andre, in our next board meeting, see how, as SHEM, we can introduce some proposals of metrics to this social determinants report. On the health and economics report you mentioned, Council, yes, we would. I mean, from my personal point of view, I would very much like to contribute. The thing is, I've been working on this for all my life, but in the last 15 years, publishing and working basically in the academic world, there is a point where the mindset of our, let's say, mainstream politics and economics, and even the academic, call it right or left, has some kind of blockage to understand and accept that there is an excess threshold above which there is negative effect on the planet and on the lives of others. So this excess, and that's why very often when I mentioned in the identification of best feasible levels of health, it kind of hits a wall. People are not prepared to say we can live with less, and second, we can probably not live so long and stretch our lives to the limit while others do not have the basics. So it is very controversial, the way to address dignity and excess, and the way, therefore, with those different references to estimate the burden of health inequity, which, in my opinion, in my humble opinion, I don't want to be overcritical, but a lot of what we do in equity is measuring inequalities by different variables. The WHO Equity Monitor has not been measuring unfair inequalities, but has been measuring inequalities across variables. So, for instance, you have the income quintiles, and you see how different under 5 mortality or life expectancy is across quintiles. But which is the quintile below which you should be addressing social economic justice? That is nowhere. We also measure inequalities across gender education, which clearly is a factor. But where is the baseline of social justice, and which can inform? And at country level, this has, for instance, been taken by some countries. Andres knows, he's in the call, how at a time the Ministry of Health in Uruguay under Mujica was keen in having some, for instance, geographical mapping of health inequities, and therefore informing territorial cohesion like we do in the EU, or fiscal equity, and so on. So yes, we will keep trying, because I do think, and I don't want to sound how can I say, presumptuous or vain, but I do think that this method is a very simple method, but by addressing lifestyles which are of well-being in sustainable equity, wise references. So probably this buzzword makes a difference and attracts more audience or readers. We change many things. We change the development models. We change the concepts of economic justice. We change as well the respect to planetary boundaries. We question lifestyles which are predominant in high-income countries that are damaging the rest of the world. We factor in carbon border assessment, so it's not just how our fireplaces and chimneys emit emissions, but also how our consumption is related to the emissions taken from somewhere else, which we consume and we blindly consume to a large extent. So very happy, Caroline, to share these ideas. To share it also, we can try, Andre, at the next SHEM board meeting to have a kind of SHEM contribution to both reports that Caroline was saying. Caroline, you should join our network and contribute with ideas, and I really welcome your suggestions. Thank you so much.
Thank you so much, Caroline. I wonder if we would still have time for one more comment, if our audience is still here with us. Dr. Mar, you're muted.
Sorry. I'm sorry. I said that I agree with Juan, and but probably if we look not only at WHO, probably we need to go directly to the countries because the WHO has a big umbrella, and in Latin America region, that's why the net HENA is working to analyze the situation. So probably if we join efforts, HENA is part of SHAME. So it's very good news because we are working in specific countries, and that would be more useful besides the declarations or resolutions that WHO take. Because this report was planned for this year, but is going to be presented next year. So it's 1 year later, according with the schedule originally was presented in the previous assembly. So that would be my commentary.
So on that note, I'm seeing that our audience is starting to leave. I would like to say thank you to everybody for attending. And I look forward to see you on the webinar series that's going to be releasing. Thank you, Dr. Manuel. It was a pleasure to hear in such a comprehensive explanation and such a dedicated engagement with the tool that Juan presented. Thank you so much, Juan. I feel like I understand more how challenging is this way that you're proposing us to think about something that's it's about time that we take a clear and a closer look. And I really hope that this session has helped you to connect with this peculiar way to think about a problem that we need to face for this generation and for the next one. So thank you very much.
Can I finish with one sentence?
Absolutely, Ron.
We now know more and more that there is something called waste GDP or wasted economy. This is human economic activity which does not translate in well-being, which is often undermining human well-being. And this is over half of our economic activity. We could live with half of the resources and better distributed, enjoy well-being, and prevent 16 to 18 million deaths every year. So there's a waste GDP connected to an excess unfair mortality. That's my final statement.
Very good.
Very good. And I don't know how to respond to that because I can see what you're pushing us toward, and it's fantastic. And I look forward for keep working with this. And SHAN is a movement that was built around this idea. As a movement, as a network, we are campaigning to avoid this waste that what is mentioned to us because we are all suffering from it. Thank you very much, everyone. It's a pleasure.
Have a nice
Bye-bye.
weekend.
Bye-bye. Juan, if you have a minute, I want to talk to you.
Yes. Bye bye.
Todos, Juan.
Bye.
Nos vemos
Bye to
pronto.
all. Chao, chao. Hasta pronto. Gracias,
Bye.
Manuel.
Gracias.
Dios, Andrés, Sergio,
André, gracias.
Carlos. Chao, chao.
Okay, I'm the host, so